Hello, good afternoon. I am Dr. Hyfa Mohammed, Program Manager at React Asia Pacific, which is one of the four nodes of React Network. We are an independent network that has been working in antibiotic resistant space from 2005. And first of all, I thank the organizers for giving me this opportunity. Especially, I extend my sincere thanks to Gamma for the opportunity to share few insights from our engagement with the communities. This session, I'm trying to make a specific argument on how the infection prevention, right diagnosis, and right treatment, the three things or the lessons from HIV care that has improved over the years, and which is actually what is missing in antibiotic response globally. So I'll walk through a few slides from our practical engagement with the communities that can be adapted in AMR mitigation efforts. So maybe with the HIV cascade numbers that were released in the previous days of the conference, if you just try to equate, undetectable equals untransmittable principle, it is in a way analogous to antimicrobial stewardship. Sustained appropriate treatment protects both the individual and the people around them. So here's the argument this whole session rests on. Antimicrobial resistance response doesn't need novel techniques or tools. It rather needs adherence, infrastructure, and cascade accountability that the HIV programming has already built and tested at scale over the years. So maybe just a snapshot of why addressing AMR isn't a side issue. In 2021, bacterial AMR was associated with 4.79 million deaths globally, of which 1.14 million deaths were directly attributable. This is from GBD study of 2021. And I'm not comparing these to compete for attention. I'm comparing them because AMR is directly attributable for mortality that already exceeds HIV's annual toll, and it's on a steeper trajectory. The forecast projects 39 million cumulative AMR deaths in 2025 and 2050, and nearly 3 deaths every minute sustained over 25 years. These aren't two epidemics on separate tracks, rather, they already collide in the same patients and in the same health system. So, why does this deserve its own rather than a folding into general AMR advocacy? Because the risk isn't evenly distributed. Clinically, increased frequency of bacterial infection due to immune suppression, recurrent antibiotic exposure from repeated opportunistic infection treatment, higher rates of hospital-acquired and resistant bloodstream infections, elevated risk of multi-drug resistant TB or HIV co-infection, all puts patient on a higher risk. Again, this compounds with equity lines where key and vulnerable populations already face poorest access to diagnostics and appropriate antibiotics. Again, women living with HIV face added barriers linked to stigma and health-seeking behavior. Here is the opportunity hiding in that. These are the same population HIV programs already prioritized, and in a way, it's a natural entry point for equitable AMR response. Moving on, if we actually have to see at an operational level, how can this be possible? One entry point that we came across in all our engagement is primary health care. PHC is where HIV, TB, maternal health, vaccination, community health programs, everything converges, making it the natural platform for AMR integration, not a parallel system we would have built from nothing. Like a pipeline, expanded primary health care already delivers HIV services, TB services, maternal and child health, vaccinations. So, AMR functions PHCs can absorb without new infrastructure like stewardship or infection prevention and control or point of care diagnostics, and rather like the larger outreach to communities like patient education or treatment literacy. Same delivery channel, expanded hub, not a new one. Maybe when I try to claim here what can be possible, it's not like HIV teaches AMR as like a metaphor, but rather HIV programs have already built resilient system assets that AMR stewardship can directly leverage on. asset for asset. For example, laboratory networks, that is existing space, or supply chain differentiated care models that can be built for retrovirals. Community monitoring or digital adherence tools are another way of bringing on board AMR mitigation efforts along with HIV. And here, maybe four HIV assets, four applications. This this whole structure need a new track, but rather utilization of the existing track effectively. Let us look at like two key maybe responses that can be one on the TB side and one on the HIV side. If you see, and in both cases we have a high death, and we have a at the same time we have a huge programmatic investment. But on the AMR side, only 46.2% of countries enrolled in the surveillance system have recommended core surveillance components in place. And this actually calls for a strengthened advocacy in that direction. And also, it's very important for us to note that antibiotic use varies widely between the highest and lowest consuming countries. A strong access and gap structure and stewardship already exist in that space. And why is it really important for us to bring on board these discussions of convergence? At this point, we see declining donor funding globally on multiple initiatives, and the stewardship can be delivered through the existing program structures of HIV and TB as well as NCDs, where all these are overlapping. And One Health agenda is again one thing that has been pushed forward in the recent World Health Assembly as well. And most importantly, with the UHC discussions increasingly treating AMR resilient health system as a baseline and not as an add-on. The practical question at any point regarding these kind of integrations is financing. With the existing channel and leveraging the HIV TB channels and bringing on board larger funds in the specific domains, or integrating these approaches in AMR can be an effective way to address AMR mitigation efforts, strengthen the AMR mitigation efforts. So it is more of like a catalytic mechanism that we are putting an integrated procurement or joint purchasing of antibiotics alongside retrovirals and TB drugs. So maybe with one of the like few examples, like another case where TB community or HIV community have extensively succeeded is reaching out to the people, whereas those currently working in the AMR space, there are smaller like models available, but the larger phase of like community-led monitoring and all these have been successfully piloted in spaces, and we have very successful models, which I've in the slides I'm not going into the details. And just maybe one thing bringing back onto the whole discussion is that the main challenge with AMR space is the One Health nature of it. How it is not just limited to clinical settings, but rather it's an interconnected pathway. And in every stage of this pathway, there is a burden that is attached to a person living with HIV or TB. And this is where we need to streamline and synergize these approaches, right from community level to the up top level of high level of policy advocacy. And again, I'm coming back to the diagnostic gaps and delays that we face, which is a good way of like bringing on forward the existing structure in HIV in strengthening AMR efforts. So where we actually stand is all of us have a role to play. Civil societies, researchers, communities, everybody bringing together. There are multiple indicators that can be put together along with the HIV monitoring system that includes prescription auditing and AMR education that can be parallelly taken forward along with the HIV approaches. Maybe just to close the session, I would be looking forward to take like few key points, and one would be like 1 or 2 points that I would really look forward to see in AIDS 2028 would be integrating AMR into the HIV strategic frameworks and indicators, and policy measurements across the global ministries and grants. And one would be an expanded access to diagnostics and community-led adherence and health literacy approaches that can be delivered. Or also, most importantly, build a joint HIV TB AMR surveillance system with a structural foundation. We look forward to discuss, engage, and collaborate with all of you. Once again, I thank for this opportunity. Have a great day ahead.